The U.S. Preventive Services Task Force revised recommendation statement on breast cancer screening guidelines was published in JAMA on April 30th, 2024. The U.S. Preventive Services Task Force is an independent group of volunteer experts specializing in prevention and evidence-based medicine. The group makes recommendations on preventive clinical services that include screening tests, medical counseling services, and preventive medications. Hello and welcome to the AJR video article. I am Wei Yang, Breast Imaging Section Editor. In this video article, I have the pleasure of speaking with Dr. John Wong, Vice Chair of the Task Force. Dr. Wong was a member of the Task Force from 2018 to 2023 and assumed position of Vice Chair in 2024. He is Professor of Medicine, Tufts University School of Medicine, Vice Chair of Clinical Academic Affairs, and Chief of Clinical Decision Making. Dr. Wong, thanks for joining us this evening. Maybe we can start off with you sharing your background in prevention medicine.
Oh, that would be a pleasure. And again, thank you for your interest. This is such an important recommendation for your organization as well as for us. I did my medical school training at the University of Chicago, came here to Tufts Medical Center a little over 40 years ago, thinking I'd only be here for 3 years. Stayed for doing a clinical decision-making fellowship in medical informatics for a couple of years, was medical chief resident. After that, I joined the staff, both in general internal medicine, as well as clinical decision-making. And I became the chief of the division of clinical decision-making roughly about 20 years ago, and have had a number of roles here. And I'm really excited to be joining you for this.
That's a really long and illustrious career. Could you share with us what made you decide to join the U.S. Preventive Services Task Force?
You know, it's a really good question as you think about how much work is involved. It was, I would say, a great honor to be invited and to be asked to join. We recognize, or I recognized, the important role that the task force holds in helping all people in this nation stay healthy, live longer and healthier lives. And as you mentioned, we're a volunteer group. And I'll just say, among all the different things that I've done in academic medicine for over 40 years now, we have conversations that I've never had before in any other situation. I've been in a lot of other sort of academic guideline, appropriate use criteria, quality measures. The conversations we have are extraordinary because we realize how important our decisions are for trying to help keep everybody in this nation healthy. Just as your radiologist, again, seek to do the same thing. We want exactly the same thing. And in particular for breast cancer, we want to help all women live longer, healthier lives through early detection.
Absolutely. In my day job at a cancer center, the mission is to eliminate cancer, but it actually is really moving the needle forward in terms of prevention and almost finding it at a level where it is hardly more than self. The topic of interest today on everyone's minds over the last 48 hours will be the revisions in the USPSTF recommendation statement for breast cancer screening. For our audience, could you summarize that at a high level with the key takeaways for the revised statement?
Absolutely. So the task force in this 2024 recommendation recommends that all women get screened every other year, starting at age 40, to help them live longer, healthier lives. And it's important to know that the latest science shows that more women have been getting breast cancer in their 40s for many years at a rate of 2% per year increase, year over year from 2015 to 2019. And because of that increased incidence, it's obvious that it makes sense that starting screening at age 40 every other year would have greater benefit. And when we look at the population benefit through modeling, we find that by moving from screening every 2 years at age 50 to screening every other year at age 40, we have the potential to reduce deaths from breast cancer by 20%. And we all know that breast cancer is the second most common cause of cancer-related deaths in this nation. And we know that by saving 1 in 5 women, helping those who get breast cancer, we're helping 1 in 5 women live longer, healthier lives. But at a personal level, you can think about their families, think about their children, and they can look forward to having grandchildren. So I think it's a tremendous advance step forward.
Certainly, John. I think that the community at large is really excited about the expanded recommendations to have women commence screening at age 40. Many in the community feel that this is a good start, but it's not quite enough. And we are aware of data that indicates that the reduction in breast cancer mortality that's related to screening every 2 years is reduced when compared to women who undergo screening every year starting at age 40. This is also compounded by the fact that women who undergo screening every 2 years at age 40 have a higher risk of breast cancer at a later stage. Could you comment on these challenges and the differences in the recommendation that the American College of Radiology and the Society of Breast Imaging have published?
Thanks so much for that question. I'll just say our goals are shared. We want reduction in breast cancer mortality. And we recognize that modeling shows that screening every year could lead to reductions that are greater than screening every other year. When we look at the modeling data, we also look at supplemental evidence. We look at the totality of evidence beyond the modeling, which suggests that's the case. We looked at trials and we looked at observational studies. We did not find any evidence for screening every year versus every other year, except for 2. The first is an old study that looked at screening every year versus 3 years. That's an old study. That was a trial that did not show any benefit. We also looked at an observational study based on the Breast Cancer Surveillance Consortium, published in 2015. They compared annual to biennial or every other year breast cancer screening, and they found mixed results. So we could not find any definitive evidence that screening every year would be better than screening every 2 years on health outcomes. And we found that mixed data based on looking at one randomized controlled trial, albeit old, for 1 year versus 3 years, and mixed results in a observational cohort based here in the United States. When we look at the totality of that evidence, where we don't have definitive benefit, we then, as you know, not only look at benefit, we also look at harms. And we have pretty clear evidence from the Breast Cancer Surveillance Consortium, where they have data on roughly nearly 6 million digital mammograms and digital breast tomosynthesis studies, tomography studies. And so we also have evidence from that trial and from those observational data that there's an increase in false positives, consequently an increase in benign biopsies, and an increase, unfortunately, in both possible overdiagnosis and possible overtreatment, because there will be increased detection of cases that look like cancer to the pathologist. And only in retrospect that we know from randomized controlled trials that those cancers that look the same as others would never have progressed, may never have resulted in symptoms, may never have resulted in signs of disease, and may never have caused any death, but could incur the consequences of adverse effects from the possible treatments. So we had solid evidence about increased harms with every year versus every other. We did not have clear evidence about the commensurate benefit that might accrue with that. We are calling for additional research to help us clarify whether annual is better or not than every other year. And keep in mind, we then end up and land on feeling clear that the balance of benefits and harms is best with every other, recognizing that yes, every year might be more beneficial, but we're not certain. We are more certain about the increased harms. And because we're making recommendations for all women in this nation, we want to be certain, we want to be trustworthy, we want to have it based on solid evidence of the benefit versus risk of harm ratio. And we weren't quite there. We aren't quite there yet. We need more evidence.
Well, John, I think that's the good news here is that there is ongoing research to further investigate the value of annual versus biannual. I think there are many of us that feel that the false positive rate based on data available, I think what we term as the marginal false positive rate, and the number of benign biopsies that are referenced compared to life years gained from the number of increased cancers that are diagnosed with annual screening is a good model to use. So we are encouraged that more research is ongoing on this front. On the same topic, when we talk about screening every 2 years versus screening annually, could you also comment about this impact on trying to create equity amongst this specific subgroup of young women? And by this, I mean women who have a higher risk of mortality from cancers that are diagnosed young in vulnerable populations, women who have more aggressive late-stage cancers, the triple-negative breast cancers, and women in vulnerable populations that have difficulty in accessing mammography facilities, specifically in this age group. What do the recommendations that have been revised, what is the impact on this subgroup of women?
So it's a very important question. I can't emphasize enough that we feel deeply and strongly that we want all women to have reductions in their breast cancer mortality. And as one example, we know that Black women are 40% more likely to die from breast cancer than white. And sadly and tragically, all too often develop more aggressive cancers, including triple-negative cancers at younger ages. We actually looked long and hard for any data that might suggest that should we have some alternative approach to screening Black women, for example. And for the first time, we did modeling in Black women to look at specific outcomes to see whether or not we could improve that health disparity. When we did that, we did not find enough commensurate benefit to potentially offset the harm when we did that. And as you might guess, it would mean more of all those things that I mentioned. And when we think about that and when we look at the modeling, what's important to remember is that screening every other year, starting at age 40 for Black women is a good step, but it's not nearly enough to reduce the health disparity. And so we're calling for more research to understand why this health disparity exists. But overall, for our nation, we would like more research to help us understand how best to reduce health disparities across the country for everyone, across both screening and treatment. And in the meantime, we want to try to ensure that all women get that mammogram starting at age 40 and then every other year. But as you know, what's important to get that benefit from that screening mammogram is timely, appropriate, and equitable follow-up for what might be an abnormal mammogram. And then if that follow-up leads to a diagnosis of breast cancer, then treatment with effective therapy for that.
With some of the conflicting guidelines that are available for women in the country, what advice would you have for a woman who reads these guidelines but is interested in getting annual screening mammography between age 40 and 49?
So the first thing I would say is all of these organizations that have recommendations, they all recognize the benefit of mammography in helping reduce breast cancer deaths universally. What is different is sometimes the age at which to start screening. Sometimes it's the frequency of screening, but pretty much all of the organizations would recommend starting sometime between age 40 and age 50 and no later than age 50. So I just want to make sure that everyone understands that. Now, when we as a task force look at the evidence, just as I described, we find the best balance of benefit and harm to be screening every other. We also, and you have to keep in mind that we are making that recommendation across the population, across all women. We recognize, having said that different women may have different values and preferences with regard to their concerns about developing breast cancer, perhaps to a personal situation or a family history or a colleague and friend who they're aware of. Anytime a woman has some concern like that, we think they should have a conversation, bring that question to their trusted healthcare professional, and together decide, given those values and preferences, what might be best for that particular woman. We think of our recommendation at the population level, and we want women to know that we're thinking about that benefit to harm ratio in terms of everyone. And we recognize separately that women have different values and preferences. Based on the evidence of benefit and harm, we would recommend every other year. But again, there are individual circumstances that may change what a woman, single person, might want or not want. And I would encourage them to have a discussion with their trusted healthcare professional, which potentially includes, I don't want to get a mammogram. Again, I would encourage them to have that discussion because we know that mammograms help save lives.
Absolutely. I think that's one of the most important initiatives. It's the slogan that mammograms saves lives and kind of detects it early for the best outcome. I want to move on to the other area where the task force recommendations do not consider women at increased risk for breast cancer, defined as lifetime risk greater than 20%. Other organizations, including the National Comprehensive Cancer Network and the American College of Radiology, have published guidelines for supplemental screening. And several imaging modalities have been recommended, including MRI and ultrasound and other techniques for a small but very important subgroup of women who are much elevated risk for breast cancer. What efforts are underway by the task force to address this gap?
So let me just step back for 1 second and say our recommendations are for average risk women age 40 to age 74. Now, that does include women who have a family history of breast cancer. It does include women who have dense breasts. It does not include women who have a personal history of breast cancer, obviously. It doesn't include women who are at high risk of breast cancer due to a genetic such as BRCA1 or BRCA2. It also does not apply to women who have been exposed to high-dose radiation at a young age due to perhaps a cancer. And it also does not apply to women who have had a benign biopsy, but the pathology is worrisome and places them at increased risk. For those women, we would recommend that they have a conversation again with their trusted healthcare professional, because as you mentioned, there are numerous guidelines for those women who fit those higher risk categories. Now, with regard to personalized risk, we could find no studies based on personalized risk and health outcomes that we care about as a task force. We noted that there are many breast cancer predictive models available. And as you well know, many of them sometimes include different covariates. And so depending on what characteristics a woman may have, they might have a higher or a lower risk depending on which instrument they use. When we looked at those data, we found that, yes, you certainly can make a prediction for it. As a group of women with particular characteristics, those predictive models did pretty well. But at the individual level, they were not very precise. And so as a consequence of that, we're not making any recommendation for any particular risk prediction instrument, nor are we specifying a particular threshold. So yes, there are these prediction models. We've identified sort of the very high risk group that our recommendation statement does not apply to, and have not found the evidence for predictive models in helping what I would call personalized risk with precision because of the uncertainties surrounding those estimates. Again, as you well know, there are active studies ongoing looking specifically at the question you're asking about predicting a woman's risk and what that might mean.
Yep, that's definitely an important segment of our population. And in that whole cadre of women that you included, you brought up women with dense breasts, and that accounts for at least 50% of the population of women who undergo screening. And what efforts does the task force have to address this conundrum? Is a challenge in terms of interpreting these mammograms, as it's been well shown that small cancers can be obscured by the breast parenchyma, and it's a challenge on mammography. Multiple center trials globally have demonstrated benefit once again with supplementary screening technologies. What efforts are underway by the task force to provide more clarity on this subgroup of women?
So it's a really important question. The task force well recognizes that women with dense breast are at increased risk for developing breast cancer. And yet we also know that mammography does not work as well for them. On the other hand, mammography does work, but not quite as well. And so, yes, indeed, our evidence-based practice center, which has vast experience in systematic reviews and scouring the literature for high quality studies, went and looked for whether, for example, supplemental MRI after a negative or normal mammogram, or supplemental ultrasound after a negative or normal mammogram would be beneficial. And they did not find any studies that reported health outcomes, or they only reported health outcomes from an initial study. And we really need 2 or 3 rounds of that screen to be able to identify whether there is important health outcomes, such as stage shift related to supplemental screening. So we are desperately and frustrated, as well as you are, that we don't have the evidence to say whether or not supplemental screening with MRI, ultrasound, or something else might help women with dense breasts live longer, healthier lives. And, for us, at least the estimates that we've been using, it's a little under a half of all women have dense breasts. Not much different than your statement, but when we look at it, and obviously menopausal status affects that estimate.
I just wanted to clarify that my earlier statement is that there are multiple global trials that are multi-center that have actually demonstrated benefit of supplementary screening with additional tools in addition to mammography that include MRI and other technologies that have demonstrated benefit.
I can only say is we don't do the research. This is what the National Academy of Medicine recommends. Actually, there's a separation among the folks who do the literature searching from the group that reviews it. And I don't want to dispute the fact that there may be studies that suggest benefit. I will say that when we formulate our questions, we're looking at very specific health outcomes, ideally mortality, which we've seen from the randomized controlled trials of film mammography going back over 30 years, right, with 9 RCTs involving hundreds of thousands of women. That would take a long time, probably would be hard to do. What we're looking for now, and what we know, is that there are some additional harms from those studies. We see that from those studies because they can report them. We just don't have anything from our standpoint, from our criteria that we use as a task force to have greater certainty about the benefit. I would not be surprised that you're finding more things. It's sort of like high def TV versus old standard def TV, right? You can see more finely and distinguish those shades of gray better for cancer versus a woman with dense breasts. I don't dispute that. The real question is there a health outcome benefit from that? Doesn't have to be will they live longer, but are we seeing something that we feel strong enough would change the prognosis for a woman? And how many additional harms would them cause? So we do see signal on the harm side, not surprisingly, right? Because you're looking more intensely at a finer grain. The real uncertainty is what's on the harm side. So there's one study that's looked at one round of screening that I know of that showed a reduction in interval cancers, but we don't know what the second round will show in terms of stages of the cancer seen. We don't know what the third round. Again, we desperately want to have this data so that we can make a recommendation. I don't know what the recommendation will be, but you should be very confident that it'll be based on the highest quality evidence that is applicable to the women in the United States. And again, like you, we're waiting for that evidence to occur.
I want to spend a few minutes on that last point, which is about inconclusive evidence for women age 75 and above to undergo screening. With the population moving towards the expansion of the boomer population and more women in that age group with very high ADL levels of quality. What are your thoughts and recommendations for women in that age group who are well and seeking screening opportunities?
As you recognize, we have an I state for that, meaning that there's insufficient evidence for benefit and harm to make that decision about what to do. And as you well know, the randomized controlled trials that were done over 30 years ago did not include women who are 75 years and older. So we have no foundational evidence for that. We have what I call a trial emulation study of a Medicare population. So mostly 65 and older, right? That study tries to emulate what a randomized controlled trial might show. And what that found was increased survival benefit for ages 70 to 74, but no benefit for 75 to 79 or 80 to 84. On the other hand, our CISNET group, sponsored by the National Cancer Institute, did show or suggest benefit from 75 to 79, but we don't have that corroborating evidence from some other source. And so for an eye state, because we don't have enough evidence for benefit or harm to make a decision, any woman who's thinking about having or worried about their breast cancer risk, again, their trusted healthcare professional knows them best. They should share how they feel. The patient should share how they feel about breast cancer and their worry about breast cancer. Because again, the task force recognizes there's still a higher mortality in women in their 75 and older age group of possibly dying from breast cancer. And we know mammogram might work. We just don't have enough evidence to say yay or nay. And, the best judge in that situation is a discussion with their primary care clinician or provider and a woman sharing their values and preferences. Sometimes that value and preferences might be the screen. In other times, especially if they have lots of comorbidities, especially if their age is such and their condition is such that they may not want to have a screening mammogram. Again, from our perspective, the best decision in that case is one made between a doc and a patient, where the doc knows the patient best and the patient can share their values and preferences.
It sounds like it's moving very much towards an interactive model. And that really brings me to my last question, which is, what are the words that you would share with a woman who is aged 45 and educated, who is highly interested in understanding her personalized risk profile for breast cancer and seeking to understand the optimal screening strategy for her and perhaps her family? What advice would you give to this woman who might be listening to our podcast or our video?
Yeah. So first and foremost, I would encourage her to be screened and to be screened every other year, as well as her family members. We know it's clear from the science that more women in their 40s are developing breast cancer. We have rates that are been increasing by 2% per year from 2015 to 2019. We have solid evidence in hundreds of thousands of women that screening is beneficial. And the latest technology, digital mammography, DBT or 3D mammograms, are even better than film mammography. And so, not surprisingly, we expect the benefit to be greater. It just makes common sense. If they have any concerns, if you have any concern about getting a mammogram, let me know. Be happy to discuss that with you. But for me, thinking about the science, thinking about the data, it's clear to me that you should be screened. And for any patient who, for example, has been isolated during the pandemic, which we know has happened, if you've not been screened and you're 40 to 74, I would urge them to go ahead and call their doctor or their healthcare professional and request a mammogram to help them live longer, healthier lives. Most women will not have breast cancer, and that's great. But for those who do, there's the opportunity for you to have that early diagnosis and live longer and have a higher quality of life through early detection.
Thank you very much for your time and for sharing with us the entire process that the task force came through in order to come up with the revised recommendations, Dr. Wong. I also want to end for the audience to share with them that the American College of Radiology and Society of Breast Imaging advocate and recommend annual screening mammography for women starting at age 40. It was such a pleasure learning from you and listening to you. Thank you so much for your time.
Oh, thanks so much for your interest. And again, we're a team, right? I'm a primary care internist. You're the radiologist. I interact with our mammographer all the time, right? In particular, when there's an abnormal one. And we all know that dense breast will be mandated on reports shortly in a few months. And so I imagine we're going to have even more interactions at that time.
Absolutely. We didn't get the chance to cover that, but that's for a different day. Thank you so much, John.
Thank you so much to be with you. It's been great.